There we go. Hello and welcome, everyone. Good day, good morning, good afternoon, good evening from wherever you're joining us from. Thank you so much for joining today. This is Yuval Foundation's Global Health Fireside Chat, and it's a part of an awareness series to promote global health awareness for everyone, everywhere. So we're super excited to have you with us today. And I'll just give a few moments so that people can join. Awesome. Welcome. So I'll go ahead and introduce myself as people are coming on. My name is Faith Adole. I am the founder and president of Yuval Foundation, and Yuval stands for United Vessels of Love. We are an international healthcare relief nonprofit organization based here in the United States. And here at Yuval, our mission is to help meet the unmet healthcare and wellness needs of underserved societies. And we do that through medical outreach, health education, clean water projects, hygiene, sanitation, and other healthcare sustainability projects. One of the things that we're passionate about is global health, not just delivery, but also advocating for global health everywhere through awareness. So that's what this series is about today. Specifically, today's topic is understanding barriers to healthcare access and leveraging strategies for high quality and effective humanitarian relief efforts, particularly in Sub-Saharan Africa. So, in just a little while, I'll bring on a guest. I'm super excited today to bring on Dr. Maimunat Alex-Adeomi. She is the director of global and training implementation for global child health and life support teams at the American Academy of Pediatrics. And she also happens to be a very active advisory board member here at UVAL. Doctor, welcome, and thank you so much for joining.
Thank you for having me, Faith.
Yeah, it's always good to see you and especially have these great conversations about global health and access to care. So, thank you for joining us, and thank you, all viewers, for joining as well. So, we'll go ahead and get started. Today is really meant to be a conversation, a chat. And as I mentioned in my intro, one of our goals is to increase global health awareness for everyone everywhere. So, some of our viewers today are maybe in the global health field, working in it, or they could just be some of our supporters and donors and don't know so much about global health except for maybe images they've seen or things that they've heard kind of here and there. So, I'd like to kind of get us started by talking about like what is healthcare access. We talk about you know improving access to care. When I think of access to care, it's simply ease or ability to obtain healthcare, and many around the world don't have that. So, I'd like to share a statistic, an alarming one, and then kind of get your thoughts on that. So, less than half of Africa's citizens, some over 600 million people, don't have access to healthcare that they need. And also, the continent's quality of healthcare services is generally poor. Family planning needs on half of the continent for women and girls are unmet. So, that's a staggering statistic. Um, I'd love to get your initial reaction to that. And then maybe in your view, if you can talk about what are some of maybe the core reasons why that statistic exists? What's causing a lack of access to healthcare in Africa?
Yeah, first of all, yes, it's alarming statistics, like you said, but not surprising, even though that's a sad reality. And you had previously said access. So basically, what is access? It's the unrestricted without using the word access, ability to use healthcare services when needed, with no restrictions such as availability, cost, or providers. So on the flip side, then you ask, what are barriers to access? To access are basically the whatever restricts use of those health services and or whatever reflects lack of access to evidence-based care. And these could be grouped in, various factors that contribute to that, chief of which is finances, access to healthcare finances, because a lot of sub-Saharan African countries do not have universal healthcare coverage, where the cost of healthcare is covered for basic essential services. Only 5 countries on the continent actually have above 70% universal healthcare coverage, and that's Rwanda, Ghana, Botswana, Seychelles, and Cape Verde. So that already in of itself is a barrier to accessing healthcare, just because of catastrophic out of pocket expenses, or just cost to accessing healthcare. You then have the non-financial barriers, which, since you had mentioned family planning, I would like to use that specific area where, for women and girls and related to maternal or reproductive health, this framework was established where we call the 3 stages of delay.
Mm-hmm.
Delay to seeking care, delay to reaching care, and then the delay to actually getting care when they get to the facilities.
Right.
This simplified model just basically says a lot of times there's delay to seeking care either due to lack of knowledge of the condition or what resources exist, or lack of agency or the ability to make a decision related to care, especially since we're referring to women and girls. Then there's lack of access to reaching care because of facilities that are several kilometers away from place of residence, or bad roads, or lack of transportation. And then when people do reach healthcare, there might be restrictions to accessing care because there aren't enough equipment and supplies, or enough healthcare workers, or they get and there aren't enough spaces or beds. So those contribute to multiple levels of why we haven't gotten to universal healthcare coverage, or there's barriers to accessing healthcare. And of course, a lot of it also plays into governance, political will, leadership, and several of those factors that we can keep talking about over and over again.
Right. Absolutely. Thank you for that. That was quite comprehensive, and as as our viewers can tell, it's multifaceted. There are several barriers. When you hear the word access, many people just think about only proximity, maybe to care. That, oh, okay, maybe you've all or other organizations are going out into rural settings, and we are, but sometimes they're not rural settings. It could be
Yeah.
within a city. So they may have proximity, but they can't afford the care, as you mentioned,
Mhm.
or issues with timeliness. And something that I wanted to add was even acceptability as well. That could be a big barrier. And kind of what I mean by that is that there are areas that maybe there won't be, I guess, an acceptability to care that's being provided.
Yeah.
There could be cultural type of barriers, or contributing factors like maybe even language barriers, or background, or those types of things, or being provided care by a male versus a female. So it could get quite complex, but I also kind of wanted to wrap around. You mentioned towards the end, you were talking about governance. Let's kind of hang out there for a bit. I actually think that's, without getting too political, but it's something that we should mention. If people are wondering, okay, these barriers are there, these are the barriers, but how did they come about, or what's going on? And the way I like to think about it is kind of like maybe a tree trunk. So if a tree trunk is, supposed to be strong and healthy and have deep-seated roots, if that tree trunk is, governance, for example, but there's breakdowns there that are supposed to feed into the different branches of the tree, that might be a healthcare sector, or might be a finance, education sector, and these are broken down, then you see a breakdown in the fruits that tree is supposed to produce. affecting every single area that we've mentioned. So I'm very visual, so I like to think of things kind of in that way. But I wanted to paint a picture for some that might be wondering kind of what's going on there. And something that I would love to talk about, you mentioned there, well, I first mentioned that, the family planning needs are a huge issue. And also, women and girls are actually um, healthcare, marginalized people groups in the community. And I'd like to get your views on why are women and girls disproportionately affected? What's going on with those groups in comparison to others?
That's a great question. And first of all, I just want to echo your visual of the tree trunk and the roots and the branches and the leaves and everything, and how that is all
Yeah,
built in on the outcomes, right? And
exactly.
then
Yeah,
when we talk of health services, you really think about it in terms of frameworks that have been developed in terms of building blocks of the health system. You have your six building blocks of the health system. The late Dr. Paul Farmer actually developed this simplified framework that I personally like to use, where he calls the four S's. It was modified to say the five S's, but four S's
mm,
basically: the health system, space, that's the infrastructure and all of that, staff,
exactly.
healthcare workers, systems, everything that makes it function, including governance, and then stuff, your equipment, your supplies, health information, and data collection systems, and everything, which sort of straddles between stuff and systems. So then you ask about the question of why women and girls are disproportionately affected by that. So it's a myriad of all of those things in terms of the building blocks of the health system, and something you alluded to previously about culture and the context
Right.
and some of the systemic issues that prevail, where in a lot of countries in sub-Saharan Africa and even other regions of the world, there's already gender inequality, access to education, which then influences the agency in decision making. Those cultural barriers also, where women aren't able to make decisions, not even just from a lack of knowledge, but from cultural and societal implications. And then you don't we talk about the health workforce already in sub-Saharan Africa. You already have limited access to healthcare providers, with the World Health Organization saying that you would have to train an additional 18 million healthcare providers over the next couple of years to achieve the parity that you would even get in other developed countries. And there's already gender inequality within those healthcare providers. And some of the services that women and girls seek will be best provided by people of the same gender or people that are trained to address women and women issues. And that also is lacking. So all of those things play, that we talk about, like the healthcare ecosystem. So all of those things play into why women and girls are disproportionately affected when it comes to these metrics and health outcomes.
Absolutely. You just hit the nail on the head there. Um, Speaking about, I guess, the strain on the healthcare workers, there's already just a huge lack of specialized care or specialized medical providers, especially in maternal child health, pediatrics, and many other specialties. Um, and so the workforce that's left is strained. A lot of times you see non-licensed. I've seen that providing, care in various settings. And those that are licensed, sometimes there's issues of maybe they haven't been paid in a long time, or they may not even speak the language fluently,
Mm.
but have been kind of assigned or deployed to work in an area based on a need, and many others. And that kind of brings me to, you've had a lot of experience. You've worked in Nigeria, you've worked in Ghana, and all over the world, and visited various parts of sub-Saharan Africa. I'd love for you to share with viewers some maybe real life examples of all these stats that we're kind of talking about. What does that mean? What does that look like? What are some instances that have stood out to you?
Yeah, it's funny you say, what does that mean, all the stats? There's this expression that says, what's the story behind the numbers?
Exactly.
And I would like to summarize it in terms of like the health workforce or human resources for health, and say a worker is only as good as their tools. And I would even expand that and say the environment in which they work in.
Hmm.
In a lot of countries, since our focus is on Sub-Saharan Africa, we talked about like the four S's. People don't have access to basic supplies, whether it's diagnostic or management or treatment, in order to be able to address those healthcare needs. So yes, somebody comes into the facility and then you lack access to basic blood. There's only so much you can do if a mother comes in hemorrhaging and she needs blood at that point. And that is where healthcare workers are restricted. Um,
Right.
we talk about even the ability to be trained and retrained in certain skills. If those
Hmm.
platforms opportunities aren't available, skills become rusty, and then people, if they even have the equipment and supplies, which most of the times is lacking, especially in primary and secondary level health facilities, then a patient comes to you and you're limited in scope of how to enable that. You did talk about unlicensed healthcare professionals, and that usually would occur when there's a gap in the system.
Hmm.
Several countries have deployed task shifting and task sharing, and sometimes it's controversial in terms of training other, maybe, I don't want to use the word lower level, but non specialized healthcare providers to deliver basic services, which then frees those secondary and tertiary level facilities to provide the services for which they were designed and designated for. But then again, due to those factors, when you send people to places where they don't have access to resources, there's only so much the training and skills will take them. And when you don't even have the healthcare workers to send, anyways, then
Right.
like nature abhors vacuum. So something would have to fill in. And that is what you get as a result. Back to the systemic issues, the systems within the 4S framework, is the regulatory bodies. You have to have functioning regulatory bodies and medical and professional societies that regulate practice. But then if they are not able to do that, that would lead to the rise of unlicensed professionals. There's also a factor when we talk about health workforce and why things like task shifting and task sharing emerged is sometimes there's over professionalization of certain healthcare workers, especially when you have a deficiency to start with. So you have to find those levels or cadres of healthcare workers that you train that allows for net new providers that fill the system. But in order to do that, you have to also develop regulatory bodies and
Bodies.
agencies on the side that regulate the practice and provide opportunities for them to up their skills. So basically, upskilling talent. And all of that falls in your tree and roots and trunk and branches approach.
Right.
It usually falls within the central government because a lot of sub-Saharan African countries function with a centralized system. Or even if it's decentralized with some autonomy, it's really limited. All of that governance and, like we said, connecting all the regulatory pieces really lies within the government and the systems. So when there's a lack of political will, that is the result of what you see within the system.
Right. There's a lot of many people are dying from preventable diseases,
Mhm.
illnesses, lack of water, lack of access as a whole in its various facets that we've discussed. And I'd like, I guess, our viewers, if you can shed light a little bit from your experience, maybe what that looks like. What are some of the types of maybe things that people are dying from that we wouldn't think about if we're out here? Um, what are some of the things that can be prevented and should be?
Yeah, you talk about preventable causes. I would say across the different health focus areas, maternal and child health, global surgery, non communicable diseases, a lot of the preventable causes of death would focus on lack of access to medicines. or timely interventions, lack
Yeah.
of access to, which in terms of medicines and treatment also would cover things like lack of access to blood supply. So we know postpartum hemorrhage is one of the leading causes of maternal mortality. So people lacking access to blood supplies, either because they can't get to a health facility on time, or they get to health facility and then there is a lack of access to blood supply in the blood bank, in the blood banks, that is a preventable cause of death. If people are involved in a road traffic accident and there isn't an emergency transport service that can get people from the point of injury to where they can receive care and be stabilized during transport, that is the preventable cause that you see. And then I've been in situations where, and this case particularly sticks with me, where I was training in one of the tertiary institutions, and a patient had come in having been bitten by one of the, I can't even remember what snake it was. And then he was there, we didn't have the anti snake venom. And this person already had a blood pressure of like 200 over 150, and was bleeding internally. But there was nothing we could do because there was no access to anti snake venom. That was a preventable death. And you see so many of those in terms of, again, when we talk about the various levels and barriers to getting care, is okay, he got
Right.
to the hospital, but there was no anti snake venom available. And one of the things that COVID showed us was the challenges or the gaps within the supply chains. And Sub-Saharan
Mhm.
Africa, unfortunately, is also on the, I'll say the negative side of that, because we don't manufacture a lot of those things locally, and you have to rely on them being shipped, being, cleared, and then even the cost of getting access to those. So those are just a few examples of preventable causes of death you see in the system that we shouldn't even be thinking or talking about in this day and age.
Exactly. And thank you for painting that picture because I really wanted people to see that it's the consequences of not having access to healthcare
Mhm.
affects everyday life. It's giving birth to a child, it's riding in a car, walking, getting bit by something. All of these things that you wouldn't think, wow, so people are dying from this.
Yes.
Um, but they are. So that's kind of, thank you. I think we've really kind of painted a picture for folks like what is access to healthcare, what are the barriers, and what's preventable, and why we should care. I'd love for us to kind of shift gears and talk about kind of where healthcare relief comes in,
Mm.
like Yuval Foundation and other NGOs. A lot of people have different, I guess, ideas about mission-based relief, and that could be a whole nother discussion, which we won't get deep
Yeah.
into, versus just strictly maybe capacity building. However, it seems like there's place for both and a little bit of marrying of the two.
Yeah.
But in your view, why do you think it's important that healthcare relief, still exists?
Yeah, and like you said, that's a touchy subject,
Mhm.
especially in this current climb,
Yeah.
both global and political climb, as we talk about equity and decolonization of global health and health
Mhm.
services. So really, there is still a role for relief and humanitarian organizations to play in terms of improving quality and access of care. But that needs to be done with the mindset that those are short-term stopgap measures
Mhm.
that should have that mindset of what the long-term investments are in those systems. Talking about the health ecosystem is trying to build capacity locally. So your typical short-term medical missions would come in, ship everything, supplies and all, finish the mission, and then pack up again and leave. There isn't really an emphasis of training providers or staying for slightly extended periods of time where there's an is trying to understand the ecosystem. Even before those missions, where
Right.
the setup is on doing a needs assessment to understand the communities and seeing whether a mission is even the best thing to do, or you can combine a mission with like a visiting professorship, which is like a short-term training engagement. Again, it's with that realization that everything that is done within that relief or mission framework is short term, and it's a stopgap measure that should be leading to some of those longer term investments. Sometimes some of the supplies that are even sent or used on missions are not necessarily what will be used eventually, or are not necessarily part of the essential medicines and supplies list in that country. So the
Right.
question then should be, should those even be sent,
Introduce.
especially if it's
Yeah.
at cost, is do you repurpose some of those funds to make sure you can even provide more equipment and supplies? And how do you ensure that the funds that you get as a relief or humanitarian organization can continue to build that supply? Again, knowing that the reliance shouldn't be on aid or donor funding or external organizations coming to cater to health services, is how you work alongside a lot of those countries to build the health ecosystem. This is
Yeah.
sort of oversimplifying it, but I think it just helps with that mindset and framework that going with just this short term approach could be detrimental to the system.
Absolutely.
You don't think long term.
Yeah. Essentially, sustainability should always be in view. It's
Exactly.
paramount, no matter what, I guess, framework an organization has. I think it's very important for, at the very core, to do any sort of business, even if it's a nonprofit business, with humanity in view. And that means, providing quality in whatever you're providing, whether it's services, short term or long term. If you think about here in the United States, healthcare and our various healthcare settings, we have standards, whether you're in home health, community health, in the hospital, whether you're quick through the ER or in your long term care setting.
Mhm.
So it's really important that even on the global health field, it shouldn't be any different. We shouldn't compromise in terms of quality or clinical excellence, because we still want the same things, good patient outcomes. So that actually brings me to some time back, I had written an article for Johns Hopkins called 7 Steps to Ensure Quality Global Health Missions. And in that, I had touched on a few 7 kind of steps that I thought of that are really great ideas for organizations, particularly mission-based organizations, to engage in. You spoke a little bit about it when you said assessments. So number one is really research. Is it a place that we know that it's a need, but is it a place that you must go to? Should it be you, or is it another organization that might be better? Um, some of that background research is super important. And then a must is always engaging community stakeholders, especially if you're thinking about sustainability. That's what it's all about. And what I mean when I say stakeholders, it's those that are recipients of the care themselves. It's everyone from the staff that you'll be working with, the healthcare providers in that community, government agencies, Ministry of Health, and a lot of times even cultural leaders.
Yeah.
And religious leaders play a huge part in different communities. Everybody is super important. You also talked about the detriment of just kind of going in with a colonial mindset, like, well, we know what's best for you guys, and that's what we're going to do. And for some viewers that may not know, I won't go deep into it, but there's history in that, mission based came from a colonial view or
Yeah.
framework. And that really affects kind of how a lot of missions continue to operate year in and year out. But in this day and age, with all of the information at our fingertips, I'm really seeing a lot of more talk about decolonization of this kind of work. And I think that's important. And furthermore, I wanted to mention, it's important to equip and train our teams that we're sending out there, um, whether it's short term or if you're doing work in the interim. And let me paint a picture. If a team is going out for a short term medical mission, for example, or if you even think about, maybe I'm a nurse, so travel nursing here in the United States, let me kind of paint the picture here in the West, if you're doing a short-term coverage for anything, there's sometimes weeks of preparation for that, making sure the skills are up to date. But we're not really seeing that so much on the global health mission field. And I think that kind of gives, mission groups kind of a bad rap. But a part of this conversation and others is really giving an opportunity for those that either participate as a volunteer, or if you're a founder like myself or involved in any way, to really advocate and speak up about these things. And um, if you've been doing missions but haven't been training, you can still start,
Yeah.
that sort of a thing. And that all goes, it's all about being an advocate.
Hmm. Yeah, and I would actually like to touch on that because you raise a great point in terms of this era of decolonization. Part of my work and a lot of other organizations work, like Partners in Health, and some of the global health institutes, is they are addressing that concept of decolonizing global health seriously, and it's something that has gained traction, I would say, over the last decade in the academia, but really in terms of like the implementation science field is gaining more traction, at least I would say in the last 2 to 3 years. And this is really with that lens of how do you do global health work ethically, how
Right.
do you do it in a decolonized fashion, and the onus lies on institutions that sends out volunteers or sends out residents or trainees on these global health missions to ensure that they are prepping people, like you said. um, and even some of the things, like in some of the work I do, is helping people see their own implicit and sometimes explicit biases and their motivation for wanting to do global health work. So making sure that we're not encouraging volunteerism, white saviorism, and ensuring there's equitable, global north, global south partnerships and bidirectionality. So the good thing about that is that conversation is ongoing now, and a lot of organizations are actually
Yes.
doing work to prep people to do it ethically. And in terms of even that whole mission model or global health, that paradigm in of itself, it's been challenged in
Mhm.
terms of who should be the main decision makers in global health. Like you said, it should be people in country, the stakeholders in country, where there has been inequitable power is funding. So now
Right.
is that challenge and call out to funding organizations to fund local organizations directly versus organizations in the global north. So it's going to take collective effort and collaboration, but I'm just
Absolutely.
glad to say there's a lot of momentum, at least in a positive direction.
Yeah, I've seen that momentum as well, and it excites me, and I think that's great. I think collaboration is truly key,
Mhm.
and is one of the visions, or the visions of Yuval, and it's even in our name, United. We really believe in partnering with other organizations, individuals, people to really help to, bring these issues to light and also to help mitigate them as well. Yeah, so also, I wanted to, because there are some viewers that are watching. I'm seeing some comments. Hello, everyone that are watching. We've got some of our donors, some of our long-term supporters that are watching, and thank you so much for always supporting Yuval. I wanted to actually speak to them as well, and how they kind of play into all of this, so that everyone knows. Yuval and other nonprofit organizations are public funded, and we rely heavily on supporters and advocates like you. So being a donor is being an advocate. Also, being a supporter is sharing, this live, and sharing posts and information, and all of that are ways that people can advocate. And of course, through donating. Wanted to take a pause here, and if anyone wants to donate, we'll put that on the screen here. Just taking a quick pause here because I've seen a lot of different little comments. Um, let's see what folks are saying. Yeah, true. We've got Dr. De Simone said affordable, high quality healthcare is a fundamental right.
Yes.
Yep, absolutely. Hmm. Got another one here from Ife Olua. Accessibility is the first step. Absolutely. And then, yeah, we'll take another one from Godson, Ezekiel. Sadly, quality healthcare is underemphasized in some parts of the world. Hmm, that's true. I like that. Let's kind of hang out there for a quick second. Some parts of the world. And I guess um, some might ask, oh, why, did we decide to do this live and talk about Sub-Saharan Africa? Other than, of course, Yuval is working there. But in your view, do you feel like there are certain regions that are more um, underemphasized than others around the world? And is that something we should be talking about?
Yeah, and I do like the emphasis on quality healthcare because it's not just availability and access like we talk about, is defining what quality healthcare is. And quality healthcare is basically, and this is just a very simplified definition, is the care that is needed to ensure the best outcome for the
Hmm.
individual and the system. Um, so and I think a lot of times people heavily blame funding for lack of quality of healthcare, but it's a myriad of things. Like we said again, the building blocks of the health system is the knowledge of the healthcare worker who is delivering the care. It's the availability of the medicine, the appropriate medicine that would ensure quality of care. It's even respectful care. Let's use maternal health. Quality care is also the mother lives with the best childbirth experience she could possibly have. We think of the best outcome in a lot of resource limited settings as mother and baby are alive. But then that's
Hmm.
mortality. What of morbidity? Did she live with certain injuries that could have been avoided, or that you won't necessarily know now but would have long-term effects? That's quality of care. Did she live with satisfied with the services she received? Did she live feeling like she had respectful care? That all of that is quality of care, and those are the metrics that you use to measure quality of care. And it plays into funding is just one of those aspects. Is the
Absolutely.
environment. Quality of care is, does somebody who is on admission have access to a clean toilet? Because they might go there to treat one thing and end up with a healthcare associated infection, or
Right.
like we call it the nosocomial infections. All of that plays into quality of care, and that should really be the focus for health systems in sub-Saharan Africa. Is look at health with all of these indices and work to provide the quality of care, not just availability of care.
Absolutely. I'm so glad you emphasized that. That's super important. So quality, I'm hearing quality is super important and sustainability, those things. So providing good care, not just care, and then in the long term, and really helping to build capacity. We touched on it earlier a little bit. So I wanted to just kind of bring that out and emphasize. One of the things that Yuval does, even if we do short term based missions, is making sure that we really become allies or partners with the community and let those communities really lead in our efforts. So usually before we go anywhere, of course, there's an existing gap, and then sometimes there could be an outbreak of cholera or something that's going on that would cause us to provide, I guess, immediate relief. So one, there is still definitely a place for missions and immediate relief because there are other organizations or maybe even NGOs as well that don't have that model but aren't able to deploy quickly and reach kind of hard to reach areas. Painting a picture, there was a region that you've all visited a couple of years ago for the first time called Obi that experienced an outbreak, a contamination in their stream, and that was their main source of water. It was right smack in the middle of COVID-19, like lockdowns that were everywhere. and there wasn't really movement, and people just died um, from not being able to access timely care or care at all. So yeah, we that definitely plays a role in um, you know what I'm trying to say is it's still very important for uh, relief, mission based relief, emergency relief, and all of those things. However, after making contact with such a community, one can't really turn a blind eye and say, well, we've helped you guys, we wish you the best. It's really like the behind the scenes work when we talk about quality, getting to know the different stakeholders, engaging with other NGOs when we leave, the organizations that are there, mission, Ministry of Health, etc. So that's something that's important to Yuval, and I think should be important to other NGOs as well. So, in summary, I know we've really talked about a lot of different barriers that exist, but I see that essentially it takes a lot of different multiple
Mhm.
actors to provide quality, sustainable, and accessible care. I wanted to also just kind of highlight before we go the fact that I'm excited about it. We're both Nigerians. We're both Nigerians, we're Africans in the diaspora, and we're both clinicians. And I think that's wonderful. And why it excites me is because I'm starting to see more and more opportunities like these for us to discuss and talk about issues that are near and dear to our heart or we've experienced or seen firsthand. And can you talk about, why you think it's important for us in the diaspora to connect and also to connect with those on the continent as well to
Mm.
move things forward?
Yeah. First of all, thank you for highlighting that in terms of like our roots and our origins. Before I answer that question, I do want to touch on something in terms of summarizing. The collaboration is key. So, a lot of entities, including relief and humanitarian organizations, tend to work in silos and take this very vertical approach to programming. Even multilaterals do that. But in terms of collaboration, that mindset of trying to take more of a horizontal approach and really looking into how to coordinate and hone in resources to optimize
Right,
outcomes should be essential. So if somebody is going to do a surgical mission, they could collaborate with somebody else doing a medical mission, and some of those resources could be aligned, and it actually improves what you're trying to do. A lot of those countries where we go into, you'd realize they are hosting so many people, so many organizations, and that in of itself is cumbersome. So it's making sure that there's coordination of efforts. And I want to add advocacy. Advocacy is key, where everybody who touches global health and all the different players that you mentioned have to also see themselves as advocates for improving health outcomes, where any opportunity to advocate at the different levels of decision making should be something that is a priority. One of my previous bosses used to say, because I worked with this global surgical organization, and he said, essentially, as a mission based organization, you should be working to put yourself out of business. If you
exactly.
are going back to
I
the
love
same
that.
place multiple times, then there's a problem. You aren't necessarily making long-term impact. So think sustainability and think that this community or this place will not need you because you've worked with different organizations and players through concerted efforts to improve the health ecosystem. So I think in terms of then going to your question about the importance of people like us, healthcare workers, experts in global health, international development in the diaspora, is we have access to knowledge, resources, tools that we can readily share with our counterparts. And this doesn't, it by no means says we're experts. We just happen to be beneficiaries of systems where those things are readily available to us. So it's
Right.
working with our counterparts who actually are the owners of those improved outcomes to see how we could join hands, join efforts to advocate for improved health outcomes, advocate for improved funding, advocate for a change in the power dynamics, advocate for a decolonized approach to global health, and advocate for just making sure we have a seat at the table where decisions are being made as to
Yes.
health outcomes. And there's this quote has been attributed to multiple people, but it essentially says, if you're not given a seat at the table, you build your own table. And it's using all of the resources and wherewithal we have, like establishing UVOL, to make a dent in, no matter how little, in improving health outcomes.
Absolutely. So well said. I think that so much so representation matters. One
Yeah.
of the things that will never leave me is when I first started kind of as a volunteer on the global health scene, there in a field in a very rural setting, just the, I guess, response by my peers, a positive response to see that I was there and
Mhm.
the questions that they had wanting to do something similar that I was doing, and but they had never mentioned it to anyone until they saw it, and I can relate with that, even myself, being a nurse and really gravitating towards professors that we had, like backgrounds or similar stories and all of that. I think that's super important. So I love that we get to share that, you and I. And I hope that this serves as an inspiration to others to continue this conversation.
Yeah.
The quest for access to global health will continue, and so will such of these discussions. They're ongoing, but I really want to thank you so much for your time today,
Thank you, Faith.
Dr. Maimuna, and thank you for being a part of UVAL's advisory board. And also thank you all viewers for watching today. Any last words that you wanted to share with anyone?
Yeah, thank you for having me. Thank you for giving me the opportunity to be part of UVOL's advisory board. And I would like to end with this quote. It's an African proverb, and east, west, south, we all lay claim to it. But it says, if you want to walk fast, walk alone. But if you want to walk far, walk together. So I'd encourage continued collaboration and support to make sure that we build a healthy continent, healthy individual nations, and improve the health of underserved communities worldwide.
Awesome. Thank you so much. All right. Make sure you guys follow us on all of our social media platforms. UL Foundation is on YouTube, on LinkedIn, Facebook, Instagram, everything. We're there. Be sure to like and subscribe so that you can follow this series that we're doing on global health awareness, and also to keep up on different ways that you can participate, whether it's through donations, through advocacy, being a part of our ambassador groups, volunteer in the field or our boards, etc. Thank you all so much and have a blessed day.